Hello, we are the Health Solutions Consulting Group. I'm Kate, and these are my team members, Lauren, Adam, and Mary. When we first heard about this community that we'd be working with, the initial step we chose to take was completing a needs assessment. We utilized the pre-seed proceed model in order to do this. We did this to make sure we knew as much as we could about the community that we would be working with in order to assure we could best service their needs. There are many components to the pre-seed proceed model, the first of which is a social assessment. In doing this, we surveyed the population to assess their perception of problems within the community, their quality of life, and what they felt best needed to be addressed. Next, we completed an epidemiological assessment. We did this in order to assess vital statistics of the population and observe those who are at highest risk and to assess if there were any trends. Next, we did a behavioral assessment and environmental assessment. In this, we assessed what environmental risk factors may be already affecting this population and assessed behavior to assure what was motivating them or may motivate them to change. The next component of our project was our educational and organizational assessment. We utilized this to understand what was already in place that may help them to sustain behavioral change in the future. The last component was an administrative and policy assessment. We did this to gain insight on what funding may be available, what grants may become available, and we later used this to assess the feasibility of our project.
So completing the assessment of the community helped us to understand some of the things the community was already doing effectively. They had an EHR and prescription drug monitoring program which was being used but wasn't being used effectively. They had treatment centers available for those struggling with addiction. The internet was there, but that was not being used effectively either. The close-knit nature of the community was one of the strongest resources from this community. And we accept that the provider has been willing to accept the pain as the fifth vital sign. After seeing what the community was doing well, we wanted to identify our main stakeholders, which were the community, the providers, George, and Beth. We completed a root cause analysis for the two cases we were given. George is a 64-year-old father. He's a retired coal miner and is recently widowed. The prescription monitoring program did not see that he had recently filled for an opioid prescription at a different pharmacy. There was an observed lack of coordination of care services. As a result of him being a veteran, he experienced depression, anger, and PTSD. He was also experiencing grief from the loss of his wife and fear that his children will leave due to a lack of job availability in the community. George was not educated on safe opioid usage or the severe interactions between the opioids, alcohol, and benzodiazepines. And he was not informed of alternative ways to manage his pain. Beth is also a 64-year-old widow. She experienced financial concerns when her husband died, leaving her without insurance. She was also affected by EHR issues when emergency services were not able to access her record. She experienced depression from unemployment from her husband's injury, illness, and death, and utilized alcohol as a coping strategy. And Beth was uninformed of the fact that she may have qualified for Medicaid, which would have covered inpatient recovery services. And Beth was not educated on the interaction between benzodiazepines, alcohol, or opioids. And she also did not have knowledge of alternative pain management strategies. So between the two of them, we found three common issues. There was infrastructure that could not support the community, inadequate resources for mental health care, and incomplete health education.
So in order to combat these problems, we came up with our proposed solution, which we have called the Hygeia Project. There are four main components to this, and we wanted to make sure we were using the community to their fullest potential, as well as tackling the opioid crisis from many different angles, and ensuring that the community would be able to make this a sustainable program. So the first thing we wanted to focus on was the medical interventions. We chose to focus on this first because they would be the quickest thing to implement once we were on the ground, and they would also impact change the quickest. So the first aspect of this would be naloxone. This is already present in the community and was used, as we saw with Beth. However, we do want to make sure more people know about this product and know how to use it, and this goes along with the Surgeon General's recent warning that all people should carry naloxone, so that should an overdose occur, more people would be able to react appropriately. Additionally, we'd want prescribers to promote this at all visits with patients that are on opioids, as well as people they think would interact with those that would be at a high risk for overdose. The second aspect of our medical interventions is medication-assisted treatment, so combining counseling with medications, and has proven to be more effective than either component individually. So as far as medications go, there are three main options. We chose to focus on buprenorphine. We decided against naltrexone and methadone due to the fact that the resources in the community would not be a best fit for these, as they would be harder for patients to access. So buprenorphine does come in multiple different dosage forms, also known as Suboxone. It is covered by West Virginia Medicaid, And it does require a prescriber to be licensed and have a specific DEA number to prescribe this. So if our provider is not already licensed to do so, we would provide him with the resources to become licensed. And the second aspect of medication-assisted treatment is counseling. And for this, we would want to partner with the West Virginia Telepsychiatry Program. So we wanted to work with already existing infrastructure, and this program has experience working with rural communities and would know the best way to integrate their services into the rural area. And this may take time for acceptance, but this would help fill the void of the lack of providers in the area. And then the next aspect of medical interventions would be our patient management. So the first part of this would be potentially asking prescribers about creating opioid or pain contracts for people that are on chronic opioid therapies. So we have seen this used in clinics near us, and it has proven to be effective for patients on chronic therapy. So there are a couple different components that this can include. Pill counts, having patients bring in their bottles to ensure the correct number of pills are still there. Drug tests, whether this is scheduled or just if they suspect a patient may be abusing illicit substances, requiring them to use one pharmacy to fill their prescriptions, and requiring frequent checkups to ensure that their pain is being well managed. Additionally, we would want to increase awareness of the DROP program. This is a place where people could dispose of unused opioids. This would be beneficial in that there would be less unused opioids floating throughout the community that could potentially be abused. And if this is not already present in the community, it is a very simple application process to get it installed. And the final aspect of this would be increasing internet accessibility for both the prescription drug monitoring program and the EHR. While this does exist in the community, as we saw in Beth and George's cases, it does not always function perfectly. Therefore, this is a major component of our budget. And the final aspect of our medical interventions is our medical provider education. So the first part of this would be educating providers on non-opioid pain management strategies, whether this is pharmacologic therapy like NSAIDs or tramadol, or non-pharmacologic therapy like meditation, massage, chiropractic, as well as referrals to occupational and physical therapists. And we would also want to provide pharmacists and providers with resources that they could use to educate themselves on how best to help people dealing with chronic pain or substance abuse issues. So this is just 4 options of services that would be available for providers or pharmacists that could educate themselves about medication-assisted treatment, integrating primary care with behavioral health care, as well as prescribing guidelines for opioids. And the final aspect of this would just be increasing awareness of the various screening tools that are out there for both opioid risks and mental health. So this is just one example of an opioid risk tool that could be used to determine if this could be something that someone may abuse, and to see if it would be, in fact, a good option for them.
So our second component of our project will be the establishment of a community center. And so this will provide a central location for resources and events. And we hope to utilize a building that is already existing in the community to decrease the time and the money required to build new infrastructure. Okay, so it's clear from both of our scenarios that the community is very close-knit and supportive. And we wanted to utilize this strength by establishing community leaders. And so these people will be volunteers from the community that may already be well-known members within the community, and they will help to foster sustainable change. And so although these people will not take the place of trained specialists or providers, they will be critical in guiding people to the resources and the services available to them. They will also be organizing and implementing change through our programs. And having these roles will provide these people with a sense of purpose through occupational engagement, as they will be the point person for various community changes. And they will also be sharing information within the community and ultimately bringing the community together. And so what does our community center look like? First, we'll need a director who will be paid, and this person will be in charge of recruiting community leaders and overseeing all the logistics of running the community center. For our leaders, we have under the community-based interventions, we have the leader of People Helping People, the mental health advocate, and the community center events coordinator. And under our community-based education interventions, we have our educational programming coordinator and our outreach coordinator.
So to elaborate on our community-based interventions, the leader of People Helping People will be a community member who will be in charge of connecting people with each other for support. And this program is modeled after existing programs across the states called Seniors Helping Seniors. This program relies on networking within the community to link people with others who can support them on daily everyday needs, such as transportation to the community center, light housework, personal care, cooking, and shopping. Not only will this foster community support through networking with church groups, volunteer organizations, and schools, but it will also provide companionship for everyone involved. Next, we have our mental health advocate, who will be in charge of planning, organizing, and helping to implement community support groups. These support groups will be for anyone experiencing pain, going through substance use disorder, or any difficulty in their life, like children leaving from their home. And this person will also be critical in helping to decrease the stigma around mental health conditions by putting on community talks with information on various mental health subjects, and also spreading the use of free resources like the Mental Health Toolkit, which provides fact sheets and materials that elucidate the prevalence of mental illnesses. So finally, we have the Community Center Events Coordinator. And this person will be in charge of putting together community building events like dances, exercise classes, and yoga or Tai Chi, arts and crafts nights, and bingo and game nights. And so with these programs, we hope to build a stronger community, foster relationships, provide recreational needs, and healthy stress and pain relieving activities.
The last component of our project is the leaders that fall under our educational or community-based education. The first of these is our educational program coordinator. One of the problems that we observed in this community was the need for family members to move away due to a lack of mining jobs within their community. With conversations with our community members, we understand that it would be very difficult to ask them to not do mining anymore because a lot of them have been doing it for a long time and hold a large sense of pride in this job. However, in order to allow them to keep their families together, it would be important to educate and expose them to other job opportunities that may exist within their community. These sessions will likely be held by an outside source, but the educational program coordinator, will be in charge of organizing them, and we may utilize telehealth to decrease the need for someone to travel. The next component that we observed that this person would be in charge of is a discussion on the prevalent use of drugs and addiction within their community. This person may be educated and be able to educate their community, or this may be done by an outside source. These discussions would be really important to talk about how to safely dispose of leftover medications and what someone should do if someone that they know experiences an overdose. These people would be able to point community members to resources where they could get training for naloxone or CPR training. Lastly, we realized that there's a lack of education on insurance. Currently, there are 2,000 people in the community that do not have insurance, but 45% of them are living in poverty and may qualify for Medicaid. This would be really important to educate them about the potential option for another place that they could reach out to get those services that they are in need of. And this may have helped Beth to get the services she needed for her recovery. Our last community member is our outreach coordinator. One of the observed concerns in our community is that there is currently only one working physician. While he does his job well, eventually he's going to have to retire. So we hope to utilize this community leader to help recruit more practitioners to come to the area through the utilization of potential clinical rotations at St. Mary's for healthcare professionals. Having clinical rotations in the community would encourage students to come to the community and may encourage them to stay for longer periods of time after they've been exposed. Likewise, we would encourage the healthcare professionals in their community to advocate for a rural loan repayment program within their community to serve as another incentive. Further, we hope to collaborate with these schools and create partnerships with the healthcare programs in the area, such as those at WVU. With this partnership, student projects that are already a part of their curriculum, such as handouts or videos, could be given to the community as further resources that would be free to the community. Likewise, we would like to use the students for mobile health fairs, where students could come and complete screenings on the population or educate the community about different resources. This would be beneficial for both the students and the community. The last area that we wanted to focus on was prevention of injury and pain. We would like to partner with OTs in the area, potentially through the utilization of telehealth to allow them to have a greater reach, to complete ergonomic evaluations and home evaluations for this community. In both cases, we observed that the injuries were related to work, and so making it of vital importance to assure that job safety is encouraged for all employees. Currently research states that work-related injuries cost the community 3 times that of Alzheimer's and cancer. Therefore, decreasing the rate of injury would help decrease the need for pain medication, as well as allow people to continue in their occupations for a longer period of time. Further, we would like to complete home evaluations, which would allow the elderly population to remain in their home and to do so safely. This may have eliminated the secondary injury in George's case of his ankle. This is the conclusion of our project, but we would like to talk about, and its 4 main components, but we'd like to talk about the process evaluation and how the second half of that looked. So after we completed our project, we would complete a process evaluation. This would look at if we were successful in the implementation of our project. Did we actually do what we wanted to? Were we able to find funding and grants, community leaders, and form those partnerships that we were hoping for? Likewise, we would do an impact evaluation. This would look at our short-term changes, such as naloxone, drop box usage, and confidence in the proper prescribing of an alternative pain medications from those providers. Lastly, we would complete an outcome evaluation. This would look at our long-term things, such as was there a decrease in the number of hospitalizations due to overdose? Was there an increase in PT and OT services and an increase in the perceived quality of life?
So here's an overview of our timeline for the first year of implementation. For more detail, please see the appendix. So we had 3 aspects of monetary considerations that we wanted to think about for our project. The first of which was training. Most of the training that we had was free. We had found free training for naloxone through Narcan and through the Heart, including teaching materials, educational posters, training videos, and cards and certificates upon completion of the program. There was also free medically assisted treatment and buprenorphine training through the Substance Abuse and Mental Health Services Administration. The second component was facilities and equipment, so we had to consider rent of the community center, possible incentive for the community director, and a discretionary fund just for miscellaneous items. And then we did want to try to approach that dearth of internet that they had there. So we found 2 grants that may be able to help us. We found the Community Connect grants through the USDA and the Telehealth National Grant programs through the Department of Human Health and Resources. So we had 2 big items on our budget that we wanted to address. The internet was a pretty hefty budget, but that was estimated from other communities looking for the same project, and we get that money from grants. If we were not able to get that money, we would have computers at the community center or pursue HB 3093. Another outstanding cost was the initial cost of setting up and getting rent paid for, and we try to cover those through fundraising events and small fees at the community center. So the implementation of our project would greatly affect the community and the unique lives of people like Beth and George. With the improvement of the internet in the case of George, the prescription drug monitoring program could have been more readily utilized in order to further coordinate his care. Existence of support groups could have helped him improve his coping strategies, and utilization of screenings may have helped identify and catch George's depression. Education about alternative pain management strategies and safe opioid usage may have saved him from overdose. And in the case of Beth, having an EHR allowed better coordination of care. Becoming a community leader would have allowed her to find occupational engagement, and she also could have utilized helping people to have extra help around the home. Further education may have made her more aware of the dangers of opioids and mixing them with other drugs, and Beth may have accepted treatment with her increased knowledge of insurance options. Lastly, both of them may have benefited from home and ergonomic evaluations, which may have prevented their injuries altogether. Thank you for listening to our proposal. Do you guys have any questions?
I have a question, and I think when you went through the slides, I thought I saw a slide on financial. I kind of went through quickly. So you were talking about director for the community center, and you talked about the community leaders, and there was a recruitment. Can you speak a little bit to, are those volunteer or paid positions? Is that factored into your budget?
Yeah, so the community leaders will be volunteers within the community, but our director will be paid. Yes.
And that was factored into our budget.
Mm-hmm.
So follow-up, I'm not clear where the money's coming from. Can you go over that? I'm not sure. You've got a great plan here. It requires that you have a series of outreach coordinator, community center director. Where's the money going to come for these folks?
So those folks are going to be volunteers. The only one that's going to be paid is the community director. And that money would probably come from fundraising events and small fees hosted there. So we maybe charge for tickets for dances or do art fairs or something like that, and just try to get money to pay the person.
What sort of a salary do you think would be appropriate for that position, and how many hours a week commitment are we looking at?
It would be a per diem position, and I think that the minimum wage there is $8.75, so it would just kind of a side job for that person.
You said a side job.
Yeah.
Okay. In your when you were discussing resources that are already in place, you noted treatment centers. Could you more clearly define what you mean by treatment centers in this slide, and if you feel that access to the treatment centers is sufficient currently?
I mean, there are treatment centers within the county. I think we were more referencing like the methadone clinics and the inpatient clinics. However, from the areas that we were looking at, like Delville, they were hours away. So while they are within that county and near that county, we didn't think they would be feasible for anyone in those rural areas to access.
As part of your plan, do you have suggestions for increasing accessibility to rehabilitation centers, detox centers, non-medically assisted recovery centers?
I think we were planning to use the People Helping People for that and hoping to find volunteers that would be willing to transport people there and hopefully pick them up so they could physically access those sites.
So using the sites that are already in place, using volunteers to increase
I think in the
transportation.
future, we would love to create infrastructure that would actually be in those rural areas, but we thought that might be beyond the scope of this project.
Okay, so short term, we'll use the community. I really appreciate your continued return to using community members that are already there and understanding that that's really the only way that things are going to change in the area. So
I think our further hope as well was to use telehealth in order to kind of make those services more available. There's a lot of telehealth online like counseling stuff that we found upon our research that we would love to utilize and kind of tap into, kind of like the West Virginia one that we talked about.
Was that West Virginia one? Is that Project Echo, their hub? I'm just curious.
They're at West Virginia University, so they're based out of that school, and then they have 32 clinics in 16 different counties. So they're pretty widespread already.
Good. So looking at Dr. Jones, beloved solo practitioner in this community, what's going to change for him once you implement what you're proposing here? And by the way, what does that name stand for that I can't pronounce? Hygeia.
It was a reference to the Greek and Roman goddess of health, as well as a subtle reference to the bowl of Hygeia, which is a big symbol in the world of pharmacy.
Okay.
Which is connected because it's an opioid.
Yeah, got it. Okay.
Yep.
We thought people would ask.
So what's going to change for Dr. Jones? What's going to change for that solo pharmacist?
I think they will have to accept that they will have to educate themselves more, and also hopefully from our education utilize more resources like OT referrals and PT referrals, because although we do recognize the fact that medication treatment is necessary for these people, we would like to monitor their usage more. And so, to prevent all the side effects of chronic usage, like hyperalgesia and stuff like that. And so just stressing the importance of patient and provider education is key to our program.
And I think just ensuring that they question everything that they see. I know something that was mentioned in the case is that they kind of accept what one another do without really looking at it. So I think hopefully with this and the different resources that we would provide, they'd be able to see if this was actually an appropriate first line treatment.
So you have several strategies in place to tackle this problem. Kind of talk to me a little bit about what measures you're going to put in place to know what's working and what's not.
I think our idea of using our pre-seed and proceed model was to really just understand how this is actually working. So a lot of our outcome evaluations is what we're going to assess. So are we actually seeing decreases in the number of overdoses? Are we seeing differences in community members as we survey them? Do they see a change in quality of life? Do they feel that their pain is decreasing with these other treatment options? Are we using other treatment options? So just kind of continually doing evaluations of the community throughout the process to see if there are changes happening or not.
And we also wanted to work with the community center events coordinator and possibly have them coordinate focus groups with people in the community to see how they felt everything was going and what they'd want to see more of.
Would you be open to working with community centers that are already in and adding kind of to what they're already doing? Can you go back to the slide real quick with the opioid risk tool? Just because I can't see it on mine, I would like to look at it for a minute. While you're looking, where did you find it, and is it evidence-based?
Yeah, this was, it was one that is, it was one that we had been seeing that was used in a lot of different areas, and I know personally I had seen this one used in a clinic that I was at where they were treating opioid use tools. So I think it's in the bottom, the REMS education. So the risk and education.
There are a ton of them out there.
Yes, there are. So something similar to this, not specifically this one, but just to kind of.
Is that on the NREP registry, do you know? I don't. Yeah.
I know there's a link on the bottom.
Yeah, I don't use these, so I like seeing that exists. It's not something that I cover in practice.
So with your community center, you mentioned needing to look for a space that you could rent. Have you given any other consideration to other existing facilities that may lend itself nicely to the same concept?
So our hope was to use a space that just exists and is already free without having to include that rent cost, but we realized that that might not be practical. So our first attempt would be to just, like, can we use, is there a single building we can use, or is there like rooms in a library we can use for this event and rooms in a church for this event? Like, how can we use what already exists without having to pay rent on it? But that was just an inclusion in case it ended up needing to be something we had to pay for.
You know, I really like a lot of what you presented here. The one thing that's giving me angst is your reliance on volunteer help. And I'm just curious, how deep did you go into federal funding, whether there was other funding sources available to help support some of these activities here? Because, you know, at least my experience is over time is that volunteers fade away. And if you're not paying someone to be there, you're going to start out great, a lot of good energy, and then it's just going to dissipate over time. So did you think about that?
Absolutely. There are actually some grants that are available for that sort of thing to help build community centers and stuff like that. However, I hope that in this community, because it is so closely knit, that volunteer resource would kind of replenish itself. With the case of Beth and George, they did have neighbors that were involved in there. So I hope that that sort of emotional connection to it would help them, and they would pass on their stories and kind of encourage other people to volunteer.
And although we'd start with one volunteer for each position, we'd like to eventually increase that number so that maybe it's not as much weight on one person. And the volunteer might not be the same consistently. Like, they might have different people throughout that are holding different positions within it. But we're just going to start with one.
Going off of that, we did also watch a lot of documentaries and talk to people that lived in coal mining towns in West Virginia. So there is a real need that they realize that this is a problem, and they do really want to help each other. So we're hoping that that desire and the fact that they've seen people go through this will drive people to want to be volunteers.
So my question goes back to the director, and kind of talk with me a little bit more about, so when you have a paid position, you need some infrastructure around oversight. Are they meeting job expectations? You've listed a lot of good things that you're going to need this director to do. Talk to me a little bit about your thoughts around how you're going to position that so that the person in this role really meets the goals and meets the expectations.
I think it will be important for us to recruit the right person for this job, and whether this person might already be like a central member within the community, we don't know, but
Ms. Huff, I'm sorry, for fairness, we will have to conclude right here.
Thank you.
Thank you.
Thank you.